We can insert a bit in earlier these bone grafts. Long time is during my training that the patient can after surgery suffer from his pain more than his neck pain. So it was now it's much easier. Technology add more help to the surgeon, make our life and patient life easier. However, we have some more severe injury as the body is totally distracted at that time. We need to take the body out and to do proper corpectomy and replacing it with a cage and plating surgery. Other options surgery is through cervical decompression and fusion, through lateral mass fusion, and sometimes it requires double approach anterior. So I have something we call 360 patient. We have to do the surgery from the back to decompression, then turn the patient anterior to do decompression, then turn the patient back for fusion. This is what all 360 patient surgeries is long. We did it before here in Sheikh Khalifa Ajman. This is a quite lengthy surgery, but it helps a lot. Well, other very complicated or cases trauma which includes cervical is very complicated, and the selection of surgery and the selection of patient is quite demanding. Surgery could be done by wiring only. Other techniques like transarticular screw fixation or C1, C2 particular fixation, or some cases can be done with transcontinental screw. It depends, of course, there are multiple injuries, and the surgery was selected according to the trauma. For thoracic and lumbar spine, either we can go surgery from the back for decompression, particular transarticular screw fixation, either long segment fixation, long to short segment or long segment fixation. Also, we can access the decompression from anterior or transarticular approach or retroperitoneal approach. We can take the body out and replace it with a cage and fix from the back as well. So the rest, the surgery and medication is not only the consider. We have to consider other more very important points to keep the patient survive and have a better outcome. Hemodynamics is keeping the map 85 and above is quite important, especially for the first 5 days from injury. One of the worst consequences of spinal cord injury is a hyperperfusion of the cord and for the patient. So we have to consider this very seriously. We prefer to have vasopressor and non-peripheral. We have to make sure the patient is in volumic status prior to initiation of anti-titration of vasopressor after. Migratory is 10 mg every 4 hours could be considered around the clock in place of IV vasopressor. Respiration, respiratory therapy, baseline respiratory parameter should be taken from the first side. EPGs with the patient initially evaluated. We have to consider tracheostomy for all patients who are likely remain ventilator dependent and to mean slowly from a mechanical ventilator. Retain situation due to expiratory muscle weakness with manual cuffing, manual assisted cuffing, pulmonary hygiene, and mechanical expiration as well. We have to consider mucomycin or sodium bicarbonate nebulizer treatment for the secretion as well. DVT prophylaxis, applying mechanical compression should be done as soon as feasible. Low molecular weight could start from the next once the patient is hemostasis is evident. Consider placing clinical filter for those patients who have an active bleeding is anticipated. Consider PTO extremely topic study every week. DVT prophylaxis is only indicated for the first 12 weeks post-injury if there is no acute ongoing issues. However, when the patient is subacute spinal cord injury stage, low molecular weight 4 mg per day is enough to restrict to 30 mg PLT is sufficient. So the timing of DVT prophylaxis for operative patient should start from the next day. And for operative patient can start from the second day. You can hold it in a day of surgery and start first day post surgery. Nutrition, appropriate nutrition, when resuscitation has been completed, should be started as soon as possible. Well, intubator nutrition is preferred over parenteral nutrition. Initiate impact tube feeding within 24 or 48 hours, of course, with all precautions, especially for patients with cervical cord injury. And also in a single compacted position when possible to prevent aspiration. Of course, we have to consider low carb formula. We have to determine the caloric requirements for the patient in acute phase. We have to maintain a glucose level below 180 in critically ill patients. Rehabilitation, physical therapy, rehabilitation should be consulted on admission. PT and OT start as soon as patient is hemodynamically stable. Speech consult to evaluate the swallowing function prior to water feeding in acute spinal cord injury, cervical spinal cord injury, or patients who are on halo fixation for cervical or are undergoing cervical spinal surgery. Stress ulcer prophylaxis should be continued.